Hello, my name's Ian Eardley. I've been asked to talk to you about medical legal issues in urology, particularly as they pertain to COVID-19. I have a single declaration of interest in that I'm a non-executive director of the Medical Protection Society and chair of council. I'm going to talk initially about the reasons why surgeons get into trouble medical legally and with the regulator. Then talk about the specific issues that relate to medical legal risk and COVID-19, and then hopefully give you some advice about how you might stay out of trouble in the coming weeks and months. MPS reviewed all their surgical cases over a 10-year period. MPS is an international organisation, and they identified just over 800 cases that were settled over a 10-year period. By settled, that means money was paid out to the claimant. You can see that over 50% of the cases related to trauma orthopedics and general surgery, with urology only accounting for about 5% of the cases in relation to MPS. And my guess is that there are similar figures both for NHS resolution and for the other major medical indemnifiers. Secondly, you can see that the value of the claim was very variable, as little as £120, but in some cases going up to over 5 million. Those big value claims primarily relate to neurosurgery within the surgical specialties. It's rare that urology is involved with a claim of that magnitude. If you look at the specific precipitating causes, initially, clearly as surgeons, there are technical issues. And looking through those cases, some of the successful cases were due to inadequate surgical procedures that really just weren't of an adequate standard. Collateral injury, which in urology might be a ureteric injury during ureteroscopy. Cosmetic quality, which probably is not particularly a urological issue, primarily breast surgery and plastic surgery, but could be relevant in cases of circumcision. Issues of retained swabs or instruments, procedures that were simply not completed, or choice of a wrong implant. Again, rarely a urological issue. Perhaps what's more relevant is that there are an awful lot of non-technical precipitating causes, and these accounted for the majority. And these related to poor quality records, inadequate consent processes, lack of follow-up, that is doing a procedure, then simply not seeing the patient afterwards or not arranging follow-up in the outpatient clinic for some reason or another, and inadequate support systems, so doing a test and then not looking at the result and not acting on that result. And they accounted for almost 2/3 of the successful litigation within surgery. In terms of regulatory review, there's been no specific review of the surgical records and surgical cases over that 10-year period, but a review of regulatory cases in relation to anaesthesia has been done, and it's likely that many of these issues are also relevant to surgeons as well. So in addition to performance issues, which is around technical skills and clinical judgment and communication, we get into the area of probity, which could lead to referral to the GMC for instance, not reviewing your patients prior to an operating list, leaving a patient in theatre unattended, prescribing for family members, conducting private practice during NHS time, and being unavailable when on call. Finally, the other issues relating to health, inappropriate behaviour and communication with colleagues or other members of the team, and inappropriate delegation to juniors. Although these were anaesthetic cases, it's not difficult to see how similar issues could apply to surgeons. Another way of looking at it is to look at those cases that were involved with high value claims. And I think this is where we begin to see how COVID might be relevant. Delay in diagnosis and treatment is a pretty powerful cause of a high value claim that is often likely to be settled. And delay in diagnosis of cancer is the commonest single cause of a high value claim. But in addition to these precipitating factors, there are background predisposing factors that sometimes mean a case is more likely to be pursued, sometimes even when nothing has been done wrong that's wrong. So poor communication skills on behalf of the doctor, a lack of sensitivity to patient needs, Poor management of expectations, having a patient who really expects a better outcome than you are able to give them, is often something that can lead to complaints or litigation. And poor documentation is again a background. For instance, the MPS is unable to defend perhaps a third of the cases that they are faced with because the documents and records do not support a decent defense. So what are the potential particular issues relating to COVID-19? And there are a number. Delay, I guess, is probably the most important. We're all aware that during COVID, we've lost beds to COVID patients. We've lost theatre time to anaesthetic staff and to use of those theatres for ventilators. And that's had a knock-on effect upon our ability to provide prompt diagnostics to our patients, whether it's use of scanners or endoscopy. Patients find it very difficult to access GPs during the epidemic. And finally, we noticed, certainly in Leeds, and I think many other people up and down the country noticed also, that during the initial wave, patients were scared of going to hospitals. All those things potentially lead to a delay in diagnosis and treatment. You've heard already this morning about virtual consulting and telemedicine, and although it's solved the job in many cases during the COVID academic, I think most of us would say it's not necessarily the same as a face-to-face consultation. And some of those non-verbal cues we simply don't get over telephone or through a computer screen. Even when we do see patients with face-to-face, it's difficult to believe that when you're wearing full PPE, that the patient communicates well with you. And if they're wearing a mask, again, you may not be getting the best of communication from your patient. PPE itself, I think it's only a matter of time before patients start suing healthcare professionals for contracting COVID-19 in the hospital. This was the PPE that was initially proposed for many patients, for many doctors when they were seeing patients. But now, for instance, when I see a patient, I don't only have to wear a mask and gloves, but I have to wear a visor or goggles, and I have to wear a full gown. I think it is known that patients contract COVID-19 in hospital, and I think failure to have adequate PPE is likely to precipitate claims for that reason. There's no doubt that the epidemic has been stressful for everybody. This is data that was from the BBC, from frontline healthcare staff during the first phase of the epidemic, and you can see that there were issues of anxiety, depression, and in some cases PTSD, and it's difficult to believe that we all perform at our best when we're under pressure from burnout or well-being. What many of you might not know is that at times of economic recession, medical legal litigation goes up. It's a repeated phenomenon that's been seen in previous economic recessions. It was noted around the 2008 recession. Nobody knows exactly why, but if patients are short of money, then you could see how they might be more motivated to pursue medical legal litigation. We've all been asked to work outside of our areas of comfort. I was on a COVID rota during the first wave, and indeed I've just had an email this evening to say that the second wave in Leeds is such that elective surgery is almost going to stop from next week, and I'm likely to be back on a COVID rota within the next week or two. That causes enormous concern if you're dealing with conditions that you're not particularly familiar with, and that potentially leads to fear of medical legal litigation or of complaints. Rationing, I think, was a particular anxiety during the first wave of the epidemic, that the fear that there may not be enough ventilators and that doctors might be asked to choose which patients get the ventilators. I think we now think that's less likely to be an issue as the use of CPAP has replaced the use of the ventilator. But this issue of rationing and deciding which patients get treatment is a cause of concern for all doctors. Finally, the issue of training. I think we're all aware that many of our trainees have not had the necessary or relevant surgical experience over the past 6 to 9 months. And there remains a concern that if a CCT is awarded to a trainee, that they may not have the requisite experience, certainly the experience of trainees in previous years. And indeed, I've been asked by MPS whether I felt that this was a potential risk. I certainly took the view that over a 6 to 9 month period, it probably didn't represent much of a risk. But I think that if the surgical experience of trainees continues to be affected over the coming months, there may well be consequences because of that. During the first wave, clearly, the NHS, as one of my friends says, was the nearest equivalent to a national religion. The clap for carers, I think, was an embodiment of that. I think we are, again, likely to be beneficiaries of general public support for the work that we do. But 6 or 9 months down the road, if somebody's had a bad outcome, that tendency to blame the medical profession may well return. The GMC has also been active, and they've recently put out a statement that says that they will take into account a number of issues in relation to complaints about doctors' practice. So issues around staff shortages or problems with PPE, or issues around distress and emotional trauma and working outside the normal routines will, we are assured by the GMC, be taken into account should there be a complaint about our practice. So has the NPS seen, has anybody seen any increase in litigation? Well, the simple answer is, as yet, no, we haven't. And there's a good reason for that. If you look at NPS's own data relating to delay between incident and claim, you can see that the average is 3 years, and the vast majority of claims come sometime after the event. It's simply too soon to be able to tell whether the COVID-19 epidemic will lead to an increase in medical legal litigation or an increase in the number of complaints to the GMC. Time will tell whether the issues that I've already raised will come back to haunt us and be reflected by increased numbers of complaints or of litigation. So what advice can I give you to staying out of trouble? Well, in many ways, it's the same advice we'd give at any time in terms of staying out of trouble. And there are six particular issues that I would suggest you take note of that will reduce your risk of litigation, both now and in future when hopefully COVID isn't around. First and foremost, in all patients, your purpose should be to try to deliver high quality and safe care at all times. In all cases, good communication skills with your patient, interact as well as you possibly can within the constraints that you have. Clearly, communication in relation to PPE, in relation to virtual consultation is different, but that shouldn't take away the requirement to achieve high quality interaction with all our patients every time. Rigorous consent and shared decision making is really, really important. You'll all be aware, I'm sure, of the Montgomery ruling in 2014 relating to the need for a consent process. And the GMC has recently published new guidance on appropriate consent. This is not simply about signing a form on the day of surgery. This is about a documented process that begins at the time that the decision's made to undertake surgery and is appropriately documented and appropriately takes into account the patient's wishes. I think it's important to effectively handle adverse outcomes. We all have patients who have an outcome that isn't the perfect one. We know that side effects are a consequence of all surgical procedures, and we have to be able to deal with the consequences of those outcomes as and when they arise. But in addition, dealing with patients' expectations is really important. If a patient's going into a surgical procedure expecting a better outcome than you can possibly give them, then they're going to be disappointed. So appropriate management of patient expectations and dealing with patient disappointment is an important part of the doctor's skills. It's also important you communicate effectively with all your colleagues, with your surgical colleagues, but with all members of the surgical team. An ineffective team that isn't communicating with each other will provide a bad front to the patient and is more likely to lead to litigation or complaint. Finally, I cannot emphasize this enough. Appropriate, comprehensive documentation of everything you do, every conversation you have with a patient is really, really important. If it's not there, then your defence organisation or the NHS resolution will not be able to defend you. In short, if it wasn't documented, then it didn't happen. So to conclude, patients do sue, patients do complain, and they complain because sometimes outcomes are not what they wish or what we would wish. However, there are a number of things that we can do every day that will minimise the risk of litigation. That is, communicate well, that is, document well, that is, deal with expectations. If you don't do that, then you're creating a fertile ground for complaints and litigation. I think it is likely that COVID-19 will, in due course, result in increased complaints and litigation. And I hope I've given you some ideas about how that might happen and how you might mitigate those risks. Finally, I would say that you avoid litigation by providing high quality, safe care that is patient-centered with good communication and excellent documentation. If you do that, you should stay out of trouble. Thank you very much.
Good morning, everyone, and thank you very much for this opportunity to present Owen's work at this exciting session of Innovation Fast-Tracked for Bowel Oncology. So this is one of my colleague Owen Hughes's work. This is Owen, for those of you who don't know him, and that is clearly not me. My name is Krishna Narahari. I'm a urologist in Cardiff, a good friend and colleague of Owen's over the last 10 years. I'm currently the Secretary of Section of Oncology and happen to be the Clinical Director in Urology in Cardiff. I therefore have some understanding of the work Owen's done over the last 6 months during this COVID period and its impact on him, on our patients, and on the department. When we devised this session, Innovation Fast Track for Bowel Oncology, our vision was to look at real life, real world examples of how COVID-19 has enabled certain things that we've always wanted to do, but struggled to do because of various barriers, organizational, bureaucratic, technological, etc. And how those barriers have suddenly not been an issue to do certain things. And this is one such example of outpatient referral management that Owen as an individual has single-handedly done for our department and how that has benefited our patients and our department. The reason why I'm stepping in today instead of Owen is also the reason why he has not been able to carry on working as normal over the last 6 months. And I'll explain that as we go along. So for those of you who know Owen, he is very old-fashioned. He likes traditions. He likes methods and systems. He likes everything to be filed in notes, all details and results to be filed in notes, and is not best with emails and by his own admission, not very good with electronic systems. He's also what I would describe as a hyper-perfectionist. Everything has to be millimeter perfect. I guess in his niche area of complex advanced kidney and bladder cancer surgery, that is really essential. But he's like that even in other aspects of his life and will never take a shortcut no matter what. And a good example of this is that Owen would himself do it and insist on all trainees doing a head-to-toe examination for all patients, whether they are an advanced kidney cancer extending into the heart or a tight foreskin requiring a circumcision. And that's his rule that he would never deviate from. So that gives you a picture of what kind of a person he has been over the last 20 years of his consultant career. However, COVID-19 has hit us all quite hard, and Owen and his family particularly more so. As a result of a personal health issue, he has been required to be shielding, which has meant that he has not been able to do any surgery, on-call work, or indeed any face-to-face patient consultation. He continues to be at an at-risk group such that his work has had to be completely redesigned to focus on some strategic issues for the department. And we came up with virtual management of our outpatient referral system and development of certain pathways. And this work is essentially a summary of what he as an individual has done over the last 6 months. He is very disappointed not being able to present this himself, but this is also the reason why I'm stepping in today, as he is had to look after himself. You will also know that Owen was the director of the FRCSE roll course and ran that very successfully for about 5 years. And in that, he would always teach candidates to take a thorough history, do a complete physical examination, review results starting from a urine dip to a complex imaging, be that a CT or an MRI. But because of COVID-19, both he and I have had to reflect on how we do what we do. And we've taken some inspiration from Tim O'Brien's talk about BOUS 2020 to 22, about what an outpatient consultation is anymore and how that should be run going forwards. We've taken inspiration from that and imbibed that into our practice. And I hope to show you some results of what that has meant for our patients. So to give you an idea, so in Cardiff, we're a team of 9 consultants, and we have a concept of on-call consultant doing e-referrals. So on the left side of your screen here is what our e-referral system looks like in terms of the consultant specialty, specialism, where the patient needs to be booked into, and what clinical condition they present with, and whether they're a USC, a routine, a general, urology patient, a hot clinic patient, with a free text box to be able to communicate to the GP to either accept, return the referral, request more information, or indeed redirect it to another specialty. For all our USCs, we have a drop-down menu to either upgrade or downgrade the USC referral accordingly. And on an average, as the on-call consultant whose elective commitments are cancelled because we do a round in the morning and the afternoon, do CPOD theatre and a hot clinic, we decided that the on-call consultant would do the referral vetting process, which equates to about 30 referrals a day, about 150 a week. And you can see why, if you have that volume of referrals, trying to consult with each of those patients historically has not been possible because of the volume that we've had to deal with. COVID-19, however, has had a significant impact on how urology is run everywhere. So if you look at Wales, for example, which has a catchment population of 3.15 million, served by 7 different health boards or regions or hospital trusts, if you like, we generally get about 5,000 outpatient referrals per month across the 7 health boards. And since March, that dipped significantly to about nearly half, nearly about 2,000 referrals. But we've noticed, as I'm sure most of you have, these numbers have gone up and consistently seem to go up to coming back up to our current numbers, which match pre-COVID levels. And when you replicate that to what has happened in Cardiff, which has a population of 0.55 million for core urology and about 2.5 million for tertiary complex work, that is pretty much exactly what we see. About 600 e-referrals from primary care per month, which dropped down to about 200 to 250 in the peak of April, and has gone back up slowly towards 500 thereabouts currently. And here is a trend of what things were like back in 2019, the blue graph, versus 2020, and how things dipped as a result of COVID-19 in April and slowly started picking up as late as September. So overall, for the period of March to September of 2019 versus 2020, which is the period we're looking at for this piece of work, which is also the period that has been most affected by COVID-19, our total number of referrals have dropped by about 60%. This has given us a window of opportunity to look at how we do things and how we do things differently. It has required the consultants who have been working in the hospital to focus more on emergencies, because we all know things take much longer to do than they used to before. But it's also allowed for Owen particularly to do things slightly differently. If you break down the number of referrals we have into subspecialties, the bulk of them happen to be oncology and core urology, as most of us would expect in a typical hospital setting. So the principles Owen used, and we thought we used these principles for all patients, would be a detailed review of medical records, existing scans, historical scans, a very proactive e-advice to the GP to return the referral with very clear guidance as to when to re-refer and what to recommend in terms of re-referrals. For patients who required a consultation, a very prompt telephone consultation, often within a matter of 48 hours from referral, arranging tests and then doing a follow-up call, again equally promptly, to conclude their management. Patients have found that very, very useful and have been very receptive to that without a formal communication about an outpatient appointment. For a select few who require face-to-face consultation or indeed an admission, Owen liaised with one of us in the hospital and would book them into our clinics and had free access to book those patients into our clinic slots. This has also required a very strict enforcement of USC guidance, and we developed some very aggressive primary care pathways in conjunction with primary care to try and manage the patient at the point of referral appropriately without undue waits just for certain tests or scans. And in simple terms, virtually most urological conditions are amenable to virtual management initially, at least. And that is what we've found. And the result of all of this has been that the proportion of patients we've consulted with virtually, or Owen has consulted with virtually, has significantly increased in this period of March to September 2020 in comparison to same time last year. And it has to be specified here that this is a single consultant managing them virtually, because all of us other consultants who've been working in the hospital have had other duties to take care of, including face-to-face consultations, on-call emergencies, operating, etc. The impact of all of this has been that about over 50% of patients who would have ordinarily required an outpatient consultation face-to-face have been managed exclusively virtually and discharged. So our requirement for face-to-face has halved during this period. This has only been possible because of very prompt, responsive outpatient management at the point of referral, and is now part of senior consultants' job plan. So 2 consultants have taken that on as a formal job plan session instead of a traditional new outpatient clinic. And as it happens, will be part of new consultant job adverts, because you could question, why go back to an old system, whereas this system works quite well and efficiently? This has required working in a different way, some support systems, nothing too out of the ordinary, frankly. It does require a good telecom system to be able to communicate with the patient while accessing multiple results. This is Owen's desk at his home. This is his mobile phone, and some digital transcription, digital dictation software to be able to transfer electronic audio files, etc., for typing to happen fairly promptly. Like with most things in an NHS practice, the most important person here has been Gemma, who's Owen's secretary, who's been the center of all of this, really, to be able to manage and run this service in a way that nobody gets left out and patients are and the results are acted upon really promptly. Feedback from primary care and patients has been fairly positive. There have been no complaints, formal or informal, so far. We are in the middle of doing a PREM analysis in terms of patient experience of their service. And the take-home message being over half of our patients who were referred via e-referrals have not required a formal outpatient consultation. So in conclusion, COVID-19 has required us to work differently, but it's also given us an opportunity to do so. It has been a difficult time personally for Owen and his family, but he continues to be driven by a strong desire to make a difference, as always. And this has been a very successful project, I think, and I think defines the new outpatient clinic model. There are certain risks in that none of this is documented in the notes, and the way we've negated that is by communicating directly with patients rather than through their GPs, which is in keeping with GMC guidance. And Ian, later on in the talk, will discuss about the medical legality of all of this. But overall, this has been a very positive experience for our patients, for Owen, and for our department. Thank you.
So my name is Ivo Dukic. I'm a consultant urologist at University Hospital Plymouth. I'm going to be talking about technology in the post-COVID-19 era. As you can imagine, it's quite a wide remit, but so I've tried to narrow it into a few different areas, including video calling, messaging, education, and artificial intelligence. If you have any other ideas or have found anything else useful during the COVID-19 crisis, you can use the tweet BAUS 2020 Tech, and you can try and share with other people as well. So firstly was video calling. So at the start of in March 2020, the NHS Digital provided free access to attend anywhere. This was given to all NHS trusts during the COVID-19 crisis. It's a web-based video calling platform, but still needs integration with local admin processes, including booking, outcomes, and coding. It's important that it's also tested with patient processes and local problems are resolved, such as bandwidth problems, software problems. And I know that we've had problems during the COVID-19 crisis of having sufficient amount of webcams available, as well as having microphones and access to electronic records, which has also been an issue. Obviously, there are other platforms for video calling, and video calling is quite a wide remit. But the essence of Attend Anywhere was that it's an easy to access video calling that can be used by anybody with a computer, in essence with a webcam. In terms of messaging, one of the things that's often the case with technology is that if tools don't exist, people will find workarounds. So in the case of messaging, people have been using WhatsApp for some time to replace previous uses of bleeps and calling physical phones. The best way that has been done is with clinical messaging apps, but instead of using the clinical messaging apps, most teams in medicine are often using WhatsApp in clinical environments. There are certain issues with using WhatsApp, including that it's owned by Facebook, and there have been issues in terms of knowing who has access to the data. Although the WhatsApp communications are all encrypted end-to-end, it is thought that Facebook does have and does use the data for further interrogation of it, and nobody knows what the uses are of that data, as well as what the GDPR compliance is. So using it for clinical purposes is likely to be problematic in the future. There's also issues with exporting data from WhatsApp, and that is also going to be problematic in the future. In terms of clinical messaging apps, there are a few apps that have been designed specifically for clinical messaging, and these include Silo, Hospify, and Pando. They're all designed to basically replace WhatsApp in terms of that use. They're all secure, and they're all designed specifically for healthcare. They all have slightly different interfaces, but work in a similar way as they're all clinical messaging apps. In terms of Silo, you can create cases and share photos and files regarding patients. These can also then be saved and exported. In terms of Hospify, it's got a more of a messaging focus and is designed to replace group communication. It looks less useful to me than Silo and Pando, but it's just a subjective measure of how effective the user interface is more than anything else. And in terms of Pando, which was previously called Forward, this can create tasks for individual patients, which seems to make it quite useful in terms of in a team environment where you wanted to work out who's doing which particular task, which tasks have been done for individual patients, such as ward jobs. It seems like a useful method of proceeding. As I said, they're all slightly different, all have pros and cons, so it's worth checking out and picking one of these to work with your team. A lot of the other software has been done to what's previously been used by software developers to try and manage projects. So one of the things we've picked out was things on Slack. And Slack is essentially works by allowing channels to be created for a team, and then having messaging between those teams, which are allows people to basically communicate together regarding certain topics. The idea of it is to allow you to communicate about certain issues and get quick reactions to it, and discuss and update things as a team. The channels bit of it allows people to keep the threads and mentions together so that you can basically continue the conversation and have a record of it later, so you can go back and review things. You can have multiple projects on Slack and it can be on based on any particular thing you want to do, but it isn't designed for patient care or cases, and it's more to do with management of projects, such as if you want to set up a new part of a unit or a new area of medicine, or want to deal with something like the COVID-19 crisis. It can be extremely useful, and I know it's also been used in the COVID-19 era for SPR teaching setup. So there's various uses for it, and it's a really useful piece of software. For people who are a bit anti it, it basically tries to replace the sort of multiple email threads and put them all into one space, so that basically you don't have to send all emails to try and to all stakeholders, and you can work with a group of people. That's the easiest way I can sort of describe it, but it's sort of somewhere between Twitter and clinical messaging and email, to try and get something that's a project management software for remote working. An alternative to that is, which can also be used as an adjunct and integrates with things like Microsoft Teams, is Trello. Microsoft Teams has been given free to the NHS for the duration of the COVID-19 crisis, and also been used for various things, including MDT discussions and group work. So any meetings are often done on Microsoft Teams, and that disintegrates with Trello directly. Trello is more like a sticky board or sticky notes to basically assign what will be done by each part of the team, and when it will be done. You can create different templates depending on what you're trying to achieve, and basically give some sort of structure to a collaboration project or collaborative project of some kind. And obviously different team members can update it as things are done, and go from basically doing to be done to be completed at some point, and to be ready for integration. Obviously these are things that are designed for software developers rather than doctors, but I think it's useful to improve that in the future. In terms of education and technology, there's various things that happened during COVID-19, including Zoom lectures, which a lot of things have been done for medical students based on Zoom lectures. This includes a series of lectures organized by one of our registrars now, John Pascoe, who organized Sustaining Medical Education in a Lockdown Environment, where they organized a huge number of lectures to try and support medical student education on a national basis. And I think we need to start thinking about how this is going to be prolonged in the future. Also the free urology textbook, which has been supported by BAUS, including, which has been edited by Ricky Ellis, which is a really useful resource, and I found that this was really good for updating our urology students during the course of the COVID-19 crisis. And there's also a new setup of Students for Urology, which gives all lots of resources in terms of educational resources for teaching urology. And obviously then for CT trainees, as high trainees and consultants, the BJUI knowledge is continually updated, and the EU guidelines provide an excellent resource for education. I think in the future, there's also hopefully opportunity to get podcasts and other things which should give us some sort of multimodality for education. But that's relatively poorly developed from what I've seen in terms of different environments. There isn't really any good podcast series that is comprehensive enough to be an update for urology. The other thing I was going to touch on is artificial intelligence pitfalls. I said there's been a lot of talk recently about artificial intelligence and how it'll replace what we do, and how and replace doctors in the future. We've got to be a bit wary of it, especially because at the moment there's no regulation of this field at all, and therefore it's difficult to determine what is actually useful and what isn't. Artificial intelligence is commonly seen as a replacement, but actually it's usually just machine learning. and all of it's it doesn't tend to learn at all after a data set has been trained on a particular set of outcomes. You can basically get reproducibility just on that set. Very rarely is there any actual continuous learning by any artificial intelligence system. The accuracy of any machine learning is therefore data quality dependent, and it tends to just be a black box system, so we don't know what the logic is of the system. We can only sort of work out the sensitivity and specificity of the system once it's learned on a set of data. The problem with that is that the data has to be real world data and accurate and reproducible in other settings, and therefore you need to have independent validation and check the reproducibility in other settings. But as I said, there's no regulation of this, and companies are often willing to forego a lot of this and not tell you whether there has been sufficient testing and allow testing of those systems in other fields. There's also problems with medical legal aspects of determining whether the artificial intelligence system will be able to work in another setting, and if you employ it, who ends up being liable for its use. But a lot of these things, I think, over time will get better. So what does the future look like post-COVID-19? So I think there's going to be more remote working, which is obviously already happening. I think video and telephone consultations are likely to be the standard for follow-up consultations long term. This will hopefully reduce the amount of people that are required in hospital at any one time, and hopefully allow a lot of working to change to improve both patient working lives and doctor working lives. In terms of big data and AI, they will improve the population outcomes. The biggest problem for that is whether big data can improve individual outcomes rather than populations. But I think that's still a work in progress in terms of urology. There's also going to be virtual clinics. I said there's going to be a bigger trend to have more and more virtual clinics, I suspect. And I think we need to develop tools to allow people to be assessed at home in terms of everything from fitness to allow virtual clinics in terms of reviews of particular conditions, which can be assessed remotely, especially with imaging as it is currently. The NHS itself will transition more and more towards cloud services. So a lot of the software that's currently held by local servers in local hospitals will move towards the cloud, which hopefully can mean that we can work easier across many trusts and share workload, especially as the IT services can then be done in the cloud, and hopefully it make our doctor or urology population allow us to work remotely, even for other hospitals if needed to be, and shift how we deliver the delivery of services. And then in terms of management, I think if we started using more of the software that I've suggested in terms of project management software, hopefully that can allow increased transparency and communication within the NHS with our clinical, in terms of clinical management, such as having shared clinical and management dashboards so we can have live views of what we're actually dealing with and what the pressures are, and also improving the stakeholder involvement so that we can all work out where we are at any one time and what are our priorities. I think this will hopefully lead to improved outcomes for patients, and as well as easier management for both ourselves as clinical managers, as well as the NHS management structures. That's all I was going to say. If you have any questions, obviously I think they're going to be done at the end of the session.
Hello, my name's Toby Page. I'm a urology consultant at the Freeman Hospital in Newcastle. I've got an interest particularly in patient communication, really important part of being a surgeon. I'm going to talk a little bit today about EConsultation, what it is, where we do it, how we should do it, what we could do better, and how it's affecting things in the COVID era. Strictly speaking, EConsultation is a web-based platform. Online, patients submit symptoms electronically, can be used particularly in primary care for triage. Studies have shown that actually you can process e-consults very quickly, and most don't need face-to-face contact. It's very useful perhaps in urology for self-reporting management of long-term conditions such as prostate cancer or stone disease. A few units around the country are using it, and there are a number of platforms that we can use. The most well-known is EConsultNet, run by the NHS. Can be both on your iPhone, smartphone, desktop or pad-based, and probably an underutilized resource in most urology departments. What about the landscape? Well, if we look at outpatient consultations in the NHS, looking at HES data from a couple of years ago, this is big business. 123 million outpatient appointments, of which actually only 96.4 million attended. So that's a lot of DNAs. Looking at historical data, the number of DNAs is actually going up, and there's been a 150% increase in the number of appointments that hospitals themselves cancel. So clearly a lot of wasted doctor time and a lot of wasted patient time. What about urology itself? Looking at urology data, just over 2.5 million outpatient urology consultations in the UK. The vast majority of those in new patients were face-to-face, just 1% in 2019 were done by telephone or video consultation. Reviews, slightly higher rate of telemedicine or telephone or video consultation. What about other specialities? If you look at orthopedics, actually a much higher rate of first consultation being done by telephone, often being triaged by physiotherapists or specialty trained nurses for that first consultation. On the other hand, general surgery, much like ourselves, with very low first face-to-face appointment, and the majority of previously being done by telephone for follow-up. What's happened with COVID? Clearly, COVID has changed everything very dramatically, very quickly. Whether this is a good thing, only time will tell. But here in Newcastle upon Tyne Hospitals Trust, where I work, the RVI, Freeman and Vitality and Aging campus, in the 2 months of April to May, if we look at our data for those 2 months compared to the year before, we've avoided 1.2 million patient miles of travel in and out for their appointments, 60,000 hours of patient time coming into the hospital and then going home away. Huge numbers, and this is just one hospital, albeit quite a large NHS trust. Lots of CO2 saved, lots of emissions. So really a good thing if your hospital is thinking about becoming a little bit more sustainable. If you think about the amount of carbon dioxide we're saving, this is just 2 months worth of data for one hospital, 3,200 trees growing for 5 years. So really good impact on the environment. How should we go about doing the ideal consultation by phone? Well, the people who've been doing it the longest, funnily enough, are in Australia, in the Outback. Royal Australian College of GPs have been doing it for years, and they have really set out a really good framework to do it.